So, yeah. Hi, good night, Mariana. Nice to meet you. Oh, Natalia. I got confused watching Mariana, but well, that's okay. Well, let's wait. 2 minutes more and then we start, okay? So thank you for being at 8 o'clock. It's nice to watch in that way. And well, let's wait a little bit. Bye-bye. I see you in 2 minutes. I'll be back. Well, good night, everybody. Well, it's your choice. Do you want to start now, or do you prefer to wait for a little bit more? Hi, is anybody in there?
It's okay to start, but there's just a few persons inside of the group. I think that it's better to wait. Where is your choice? It is the choice of everyone.
Yes, actually, it's your choice. We have a 1 hour class is prepared in that way. But if you prefer, we can start now and finish at 9 as it is organized, but it's your choice.
We can start now, Doc.
Yes, everybody everybody agree, I mean? You want to start?
Yes, Doc.
Okay, so let's go
Let's
ahead.
go ahead.
Okay, can you watch my screen?
Yes.
Okay, yeah, green one. Well, this week is our last full week together, I mean, because in order, we were talking last workshop, we have our final test in 7 or 8 days. I'm not sure at this point, but it's close, I mean that. So this part of the course is interesting a lot, I think, because it's one of the objectives we are following during the whole course since module 1. And well, now it's a good moment to start with this, and of course finishing on time. So let's go ahead. Today we only have one great topic, I mean. I think it's the biggest one we are looking for. And it's taking a medical history. And in order, it's a great point to start working on. It's a good moment to check the details that I was telling you. In this class, we are going to talk about the whole elements, and I'm going to send to the group lots of models just as an information files about many different ways of clinical history, and then you're going to see all the charts I was telling you. Some of them for collecting general data, other ones for collecting pathological antecedents. Well, details that of course are important, but are organized in order for not rounding information. So let's go ahead. A full case history. A full case history covers all of these topics: personal details, presenting complaint, past medical history, drug history, family history, social and personal history, patient ideas, concerns, and expectations, of course, very important while talking, and review of systems that we all know how to do it, of course, and we are practicing about it during our exercise writing down, of course, according to the clinical case you chose at the beginning. You chose one that is similar for you, that is great for you, and it's easy for working. And in that order, that clinical case is, well, a good way to start writing down. This week, we're going to check specific expressions about all of these details, this information, and how to take it without missing or mixing information, okay? Okay, personal details. In many countries, we have people that are just prepared, just in the position to take personal details to patients. Here in Bolivia, for example, we have nurses that do that, or maybe another kind of workers, not medical workers, I mean just general workers, for taking full name, number, health insurance, for example, the details like that. That's why normally patients' personal details have been entered in their records by a nurse or administrative staff before the doctor sees them. So you can see, when we, for example, go to the, I don't know how to express that, to vigencia de derechos, for example, in lots of insurance, in hospital insurance, we get the administrative taking the information for opening the file, and then we can get to be checked by the doctor, right? However, on later consultations, a doctor may wish to check details such as address, date of birth, occupation, or marital status. We all know the importance of this, and we have to be sure that every data, every detail is correct. Sometimes administrative can mix a number or exchange a detail. It happens because they have lots of jobs. It's not an easy place for working, but we have to consider that as a doctors, we just check and complete if there is something missed. To find or to check a patient's occupation, we have this specific 2 questions. Do you work? Do you have an occupation? Something like that, that is inferring that is taking the detail. What do you do? And then you can complete this. What do you do for a living? So it's important because of all the risk we know, right? And patients usually may respond, no, I'm unemployed, or maybe I am out of work. You can see the same answer in 2 ways. Another way, no, I'm retired, or I'm a pensioner. Again, 2 answers, the same meaning. Or then, yes, I work for a bank, for example, or I work in a factory, for example. So you have 2 cardinal questions in the easiest way, but if you find a similar question that gets to the same objective, it's perfect. Just don't miss the point about asking for occupation. About marital status, as a doctors, we ask, do you have a partner? Partner, of course, is without taking a sex, taking if he is a husband or wife. Well, of course, we all know the reality, the social reality at this point, so we don't have to infer that all of our patients have the same sexual orientation that us. That's why we use partner as a general gender, for not mixing information nor offending anybody. Susceptible people is everywhere, so let's have to ask. Let's make a correct question for doing it correctly. And then we get our response. No, I'm single. No, I'm separated. No, I'm divorced. So you see 3 possible options. Another way. No, I'm a widow. No, I'm a widower. No, I'm divorced. You see, again, 3 questions, 3 possible answers. The easiest one, yes, I'm married. It's not important if I'm married with if I have a husband or wife, but we have another ways to make this answer. I live with my partner. I live with my spouse. Could be husband or wife. Spouse is the same, it's general. I live with my husband. I live with my wife. So you can see the patient has the open key to tell us who is living with him, right? Or we can receive this answer. My spouse passed away last year. A spouse, of course, is a general gender, passed away, the partner dead last year. So this patient is a widow or a widower, according to the case, okay? Look, let's look this. That's the meanings that I was telling you. Spouse can be wife or husband, of course. Widow is a woman whose husband is no longer living. Woman, widow. Widower is a man whose wife is not longer living. So let's remind this. Widow for woman, widower for man. To avoid saying someone is dead, to use another kind of words or a kindly way to express this idea, patients may say that a person has passed away. This expression is very, very, very common. More than you think. It's not passed away to go away, passed away because it's dead. So let's take it into consideration, okay? And let's try together not to mix the meanings. Well, now let's talk about pain. Why pain? We all know as doctors that pain is one of the most common situations we're going to visit a doctor to make an appointment. So when we talk about pain, we have to consider that is a non-comfortable situation, of course. So in case notes are kept for each consultation. Of course, we all know every patient has its personal case notes, case report, and the presenting complaint section of case notes records the patient's symptoms. So we have this example, the same as we were working during the case report, but here we have as a note, there's a resume. Right-sided temporal headache, severe throbbing. We don't need to round on details or give more words. We all know that it is in the right side, it's a temporal headache, and the character of this. It's lasting 24 to 48 hours, a lot of time. In this case, the patient complains of headache, of course, and we have the details how the headache is. That's why I'm asking for you to practice on the case report a lot. Writing again, checking again, rewriting if it's necessary. You will know of these details. Of course, we have the meaning of pain, and we have two international definitions from the IASP, the International Association for the Study of Pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Okay, one definition, international one. Another way to express this, pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. So you can see it's not just a physical situation, it could be connected to feelings too, cognitive and social situations too. So let's consider a bigger one or a detailed one. It's for you. It's just as an example and to catch some vocabulary to send you these expressions, okay? When we ask about symptoms in pain, well, we have pain, one of the most common symptoms. For headaches, a doctor would expect to establish most of the features below. Similar questions can be used for other symptoms, of course. We have all of these lists talking about symptoms and for looking for signs. And we can, of course, use similar questions for catching information. Going to pain in this example, for example, in the main site, where does it hurt? Or an order, show me where it hurts. About radiation, does it go anywhere else? So you can see about the character, can you describe the pain? Precipitating factors, does anything bring them on? So you can see we have phrasal verbs, right? Time of onset, when do they start? Time of resolution, when do they stop? Frequency, how often do you get them? Aggravating factors, does anything make them worse? Is there anything else that affects them? So you can see two ways for making the same question, but if you have one question, a different one that goes to the same objective, it's perfect. The relieving factors, does anything make them better? associated features. Do you feel anything else wrong when it's there? Have you any other problems related to the pain? So you can see about the duration, how long do they last? About severity, how bad is it? So in that order, when we ask for this kind of situations, these symptoms, trying to convert them into findings, we have this list of questions, of course, following these objectives, and they are, of course, similar to Spanish. In Spanish, we call Alicia. Do you remember the mnemotechnic Alicia? In some other countries, Alicia Fredusa. They are the same questions that if you translate them into Spanish, you have the same way, the same mnemotechnic to ask them. So try to keep them in mind. Try to practice on this because it's important to take into consideration. And it's the same as in Spanish. Maybe the order is different. That's why it could be a little confusing. But if you get to the objective, this order, of course, can change. It's your own decision according to your experience. So, well, we have the pain rating scale just as an information, but this is the most common, the easiest one. In chart, we have lots of new vocabulary, but it's just an information for giving you a detail that we have to consider this. The pain assessment scales and tools. We have associations that are studying pain. The FEDELAT, for example, the IASP that I was showing you in previous slides. And all of them get accorded that we have to try to use these tools in order to make it easier according to the place you are working on. All of these mnemotechnics, acronyms, are answering a question. Each word is answering a question. The OPQRST, for example, for trauma, ABCDE. So just as an information, I'm showing you this detail. The link I'm going to send to the group in order for you to check if you consider it's necessary, and it's going to be helpful. We have pain assessment skills in adults. Of course, we have all of this, and the visual analog scale is the one that I was showing you in previous slides. And in pediatrics, of course, we have lots. Kids don't talk, babies don't talk, but we have to look for the way to find how to ask for correctly or how to look for correctly and try to find what is going on with the kid, with the baby, in order to get the correct information. Just as an information, extra data for taking in account and practicing, because I consider it's important to be sure and be clear that this chart, it's not the only one. In order it's not the only one, well, of course, we can use any of them according to the place. For pre-hospitalian attention, for example, the OPQRST is perfect. In adults, for example, behavioral pain scale for people that it's without talking, for mute people, I mean. Numerical rating scale, well, it depends. For example, my son, always everything gets in numerical rating scale, so it's easy to talk to him. Visual analog scale, helpful if there is no way, another way to decide. And this is for us, just for doctors, for practicing and getting connected with the patient, with the baby patient, or describing the situation. And we have this study, a systematic review of the pain scales in adults, which to use. This article just talks about how the emergencies, how in emergency room, we choose the pain scale, and it's not always the correct one. You have to do it here, the specific data, and it gives you some keys to check, to look for the correct pain data scale. Just an information. But when we talk with our patients And according to the article, we have the description of pain, the characteristics that are important to consider and to use for in order to write down and get the same information, the same idiom could be said, the same language according to colleagues for not making this in discussion. Patient description of pain, it's not in that way. That's the way that natives just talk, and that's the meaning. Natives use these words. People like us, that it's not a foreigner, that it's not like a native, I mean, it's not a common word to use these expressions, but we have to practice on them. And following the explanation, some patients don't know how to express just a word, and they go with the explanation. So let's practice with both of them. Aching or an ache, a general pain often in muscles and joints. We all know how it is. Boring, like a drill. Burning with head. Colicky, an intermittent pain which varies in intensity, comes and goes in waves. We all know about it. Crampy or cramp, an involuntary spasmodic muscle contraction. Crushing, a feeling of pressure. Dull, a background pain opposite of sharp. Gnawing, biting. Gripping, a feeling of tightness. Scalding, like a boiling water. Sharp, acute. Stabbing, like a knife. Stinging, sharp, burning, like an insect sting. Throbbing, with a pulse or beat. There are the most common ones. Of course, there are a lots of descriptions. When I was working in a hospital that was receiving travelers in order for patients, of course, they used to, well, they were natives, American natives, and they used this kind of expression, and I ran mad in order that they are not common expressions. So I asked for them the explanation, and it was easy to talk. In that way, never be shy, never be ashamed about asking for the meaning or asking for an explanation of a word that you are not in a familiar situation. So don't worry, it's very common. The same, of course, happens when they are talking with Spanish natives. It happens. And this means I give you here the meanings, some of the most commons, but I give you here a biggest list how to describe them, just as an information, this second slide, this list. If you want, you can check about it, you can look for the meaning, the explanation, that's perfect for you, but this is just for information, so don't worry about it. I'm showing the guide because it's not, well, it's possible that sometimes you can talk to someone that use these words. So just for information, don't worry. We have the difference between acute pain and chronic pain, of course. The acute pain, it comes suddenly, usually the result of injury, surgery, or something similar, lasts 6 months or less, and related when causes is treated. Easy, it has a solution. Chronic pain comes on gradually, usually is the result of conditions that are difficult to treat or diagnose. Lasts more than 6 months, and difficult to find lasting relief. There is no cure, no way to solve this. Patients suffer with this all the time. So let's get the difference, that's all. About the drug history, of course, it's important for us to take this information. To talk about medication, it's not a mystery how to do it. But always, all the time, our patients are used to avoid this information and change the meanings and change the details about it. So let's be in consequence in practice of this and take all the vocabulary that it's in black and words. It's essential to obtain full details of the drugs and medications taken by the patient. Not infrequently, patients forget to mention. Sometimes they decide not to mention or forget the name of or forget the drugs they take. It's very common. Some may be over-the-counter remedies unknown to the general practitioner. This expression, over-the-counter remedies, refers to that medication that can be sold without the medical recipe, the medical indication. It's very common here in our country, of course, I think in all Latin America, all medication is over the counter, but just few of them that have the risk to be addictive are under control. But over the counter in Europe, in USA, for example, paracetamol in small doses, or vitamins in small doses, or medication that it's not a risk for the patient in small doses. According to that, the over-the-counter remedies are sold in supermarkets, for example, not in drugstores. If you go to a drugstore or a pharmacy in Europe, you cannot buy medication without the medical recipe. So never forget it, okay? The significance of others, such as herbal remedies or laxatives, may not be appreciated by the patient. Herbal remedies in our country, Bolivia, could be a trouble because we have lots of herbal remedies. But in other countries, it's not the same. They are under control. They have recipes, but they are not the same recipes that medication, of course. It is necessary to determine the precise identity of the drug, the dose used, the frequency of the administration, and the patient's complaints or lack of it. So we all know the indication about using this. And it's important to ask about known drugs allergies or suspected drug reactions. Of course, they are not the same. We all know about it. And to record information on the front of the notes to be obvious to any doctor seeing the patient. A failure to ask the question or to record the answer properly may be lethal. We all know about it. Sometimes patients don't know that they are allergic, and well, we have to be very careful about it. To find out about drug history, we can ask as doctors details of drugs and medications. Are you taking any medication at the moment? Which tablet do you take? Do you use any over-the-counter remedies or herbal or homeopathic medicines? So you can see we're covering all the possibilities. Yeah, let's ask without being shy. Let's ask, let's make questions, and then go ahead. It's our job to make lots of questions, right? About the frequency, for example, we can say how many times a day. Of course, you have the possibility to look for synonyms. About the compliance, do you always remember to take it? So don't worry. They are just examples, and you can improve these questions. About side effects and allergies, do you get any side effects? Do you know if you are allergic to any drug? Very common questions, of course. If the answer is yes, of course the patient has to answer this. What symptoms do you get after taking it? And the patient is going to describe all the situation. And according to the situation, you know if the patient is lying or not, right? About the family history, very nice topic. We have to note, we have to write down the age, health or cause of death of parents, siblings, of course, brothers and sisters, spouse, husband or wife, we talked about it, and children. All the family tree to consider to take it in account. We all know why this. To find out about family history, we can ask, do you have any brothers and sisters? Do you have any siblings, for example? How old was he when he died? Do you have any children? Do you know the cause of death? What did he die of? Are all your close relatives alive? Are your parents alive and well? Does anyone in your family have a serious illness? Is anyone taking regular medication? So in that way, making these questions, we get almost all the information. And according to the answer, of course, we make more questions. About the social and personal history, we have to record the relevant information about occupation, of course, housing, personal habits, considering recreation, physical exercise, alcohol and tobacco, or maybe the drug consumption. In the case of children, we have to talk about school and family relationships, very important topics. And we can use these questions as an example. About social and personal history, well, the typical questions. What kind of house do you live in? I mean, it's your own house, it's for rent. Are you taking care of the house without payment? For example, are you taking care on the building? Okay. Do you live alone? Who shares your home with you? Sometimes it's not family, just friends, and they become an expanded family, right? How old are your children? Are any of them at nursery or school? Nursery means the previous care for going to school. In Bolivia, the guarderia, yeah, could be. And that's important to take into account, because if they are in nursery, it's another risk for children to consider, to take as a relevant information. What's your occupation? Do you have any problems at work? So taking all of these questions just as an examples, you have the point to start and going ahead with some more questions. Let's hear. Do you have any financial problems? Very important to talk about financial situation because it's a stressing factor. Do you have any hobbies or interests? Sometimes nobody asks you about it. How do you spend your free time? Or do you have free time in order to understand the behavior of the patient, all the hobbies, all the activities that the patient is doing in order to relax and get a better way of living? What about exercise? Do you exercise? Do you go to the gym, for example? Do you smoke? How many a day? How many cigarettes a day? How many boxes of cigarettes a day? Have you tried giving up? Why we asked you this? Because it's not easy and it's very frustrating when you try to give up, like smoking or alcoholism, and then you get back and get back and get back. And of course, it gets a worse situation. What about alcohol? Wine, beer, or spirits? When we talk about the spirits, we refer to another drinks and to drugs, specific drugs, okay? Can you give up alcohol when you want? How much do you drink in a week? So you can see specific questions according to the answers. What's the most you would drink in a week? Are you aware of any difference in your alcohol consumption over the past 5 years? So you can see spirits, as I was telling you, refers to, for example, rum, refers to whiskey, refers to marijuana, refers to LSD, refers to recreative drugs, for example. Of course, they are not loyal, but we have to ask for this. And it's confident, it's confidential, I mean, and we have to consider this information in order to protect our patients' data, protect all the situations they are suffering, okay? So, as I tell you, they are just examples. If you find more ways to ask for, another ways to make the same question or to go to the same objective, do it without any trouble. Reviewing the systems. Well, we are talking about systems, all of the module 1. And just for taking an idea again, we have some specific questions. Once you know the main reason why the patient wants to medical attention, it's sensible to ask about the systems to determine the patient's general state of health and to check for any additional problems. So we look for the principal complaint, why the patient is going to the appointment. And then we go specifically first to the point, and then we look for, we all know about it. We make it every day with all of our patients. The patient should be encouraged to describe symptoms spontaneously. We don't have to direct anything about the anamnesis. We don't have to ask for anything. They have to start talking, and we just help them to organize chronologically, right? Initial questions should be open-ended and as general as possible, we know. Follow up with more specific questions if needed, but avoiding putting words in the patient's mouth. We don't have to direct the speech. We all know this, just for remind, just for taking in count, and for considering that it's important to refresh these guidelines could be said. Well, open-ended questions, for example, what's your appetite like? The patient has all the vocabulary, all the moment to talk. Or how's your vision? In opposite, we have the closed question. Have you eaten today? Yes, I have. Yes, I have not. And that's enough. About vision, is your vision ever blurry? So we are giving a specific word to the patient, and it's wrong. It's not the way. Just for information, we all know about it. About the central nervous system, we have these examples. Do you suffer from headaches? Have you ever had a blackout? We know what a blackout means. We talked about it. What about fits? We all know fits. Have you had any dizziness? Did you get ringing in the ears, knockers ears? Have you ever experienced any numbness or tingling in your hands or feet? Do you have any problems sleeping? So you have here just examples, general ones, open questions, well, closed question and open questions in order to start the patient or to give the patient confidence for talking. About the patient ideas, concerns, and expectations, we usually avoid this at the beginning because we don't have enough time to do it. Here in Bolivia, our law says that we have 15 minutes per patient. The appointment is supposed not to last more than 15 minutes, but it's impossible. We always need more time. And if it's in the emergency room, of course, we take much more time, and then we can consider all of this. It's important during the consultation to give patients the chance to express their own ideas and concerns about their problem and to determine what their expectations are. Sometimes patients even don't know what to expect because they don't have the information about the situation. They are not sure what's going wrong. But in order they get in confidence and they get the knowledge about what is happening, they start making questions by themselves, and usually they get nervous about asking for what's wrong. So we have to take the minute. It's perfect if we can take the minute, I mean, to solve the doubts, to make the patient feel confident, and to talk about it and get in a common conclusion. I mean, it's easier to work in that way. So we have to consider this, just talking, trying to save time for using these expressions, for being confident, for not wasting this opportunity. We have the letters ICE, ideas, concerns, and expectations are a way of remembering this, just an acronyms in order to remember and not losing that is important for our patients. Maybe in our cultures, in our countries, it's not a fact to use this. Well, I saw lots of colleagues that are not used to talk and solve this because time is not enough, and we must understand. But in USA, UK, well, Europe in general, you have to talk to the patient and solve all of this situation, all of the ideas, concerns, and expectations. You have to talk about it, solve the doubts, because if you don't solve the doubts, the patient can fall or can find you in a lower situation, and it's not correct, right? Questions that we can use in order to consider these ideas, concerns, and expectations. For example, for ideas, what do you know about this problem, condition, or illness, or disease maybe? What do you know? Do you have any ideas about this? Do you think you got this problem? How do you think you got this problem? Or maybe, what do you mean by? And then we complete the patient expression. We have to be ensured that everything is clear. About concerns, what are your worries about it? Do you have any concerns? How might this affect the rest of your family? Very important question. But we usually don't practice on this. About expectations. What do you think will happen? What do you expect from me? We have to be clear on this. What do you expect from me? If I'm not prepared, I don't have all the medical skills could be, I have to ask for help and call more doctors and make a team, right? That's why, what do you expect from me? What were you hoping we could do for you? What do you really expect from this situation? Not easy to ask for, not easy to answer, but we have to be so clear and sincere, could be so clear, and not mixing this information, not losing these details. And well, as an extra data, very important, we have phrasal verbs. Of course, in the social English, they are hard. In medical English, we use the same. We have to consider them and we have to practice on them. Why phrasal verbs? Because they are helping us to open our vocabulary at first, to make an appropriate question, to use the correct verb. Is easy to get in contact and to get in context. That's why we must practice. We have a short example of them, a short list, but there's a lot of information. And while reading, while talking, we are practicing on this. Maybe you didn't realize that while practicing, but during the case reports we are writing on together, I'm asking for phrasal verbs. I'm obligating you to practice on this and practicing on this. So phrasal verbs are often used in informal spoken English. Both patients and doctors may use them in consultations, in appointments. A phrasal verb maybe have several meanings according to the context. That's why it's easy to use them. It's easy to catch the meaning, and it's easy to get in context with the situation, the specific situation. For example, the phrasal verb, bring on. An example, is there anything special that brings on the pain? Is there anything special that causes, that induces on the pain, and then induces the pain? So you can see, when you said bring on, you have two options for answering or for asking, or the patient answer, okay? Bring up. When do you cough? Do you bring up any phlegm? Do you expectorate or do you vomit? It's better, it's comfortable to talk with the bring up, even vomit or expectorate. It's clear to the patient. The patient might not be confused about what you're talking about, what you are asking for. About carry on. Carry on taking the painkillers for another week. Carry on, continue. Don't forget, don't miss. Carry on, very common phrasal verb that is used in informal, in social English. That's why it's easier to understand the meaning. Come on. When does the pain come on? When does the patient begins? Here, commence. Commence is for British. Don't miss this. This in American English, it doesn't have a meaning. In British English, you have to use commence. That's okay. That's a good way. Very elegant way to talk. When does the pain come on? When does the pain commence? When does the pain begin? Give up. My advice is to give up smoking, to stop, to leave, not continue. That's the meaning of give up. My advice is to stop smoking. My advice is to avoid smoking. So you can see many meanings, many answers. Put on. I put on a lot of weight in the last month or so. In this case, I gain weight. In general, is to gain, to admit, to acquire. I gain weight a lot, or I gain a lot of weight in the last month or so. I put on. Put on is easier to understand and to catch. Turn out, she had all the tests and it turned out to be cancer. Happened in the end. Turn out to get the conclusion, I mean, as a conclusion could be, and then it's easier. She had all the tests and it happened to be cancer. So you can see it turned out easier to understand, to get it in a very comfortable way, or easiest way to talk about the situation with our patient. Turn up. The rash just turned up out of nowhere. Appear unexpectedly, without an order, without organization. The rash just appeared out of nowhere. Right? So let's practice these general ones, these common ones. I mean, I'm gonna ask for homework and final test, so practice on them. But don't worry, because all the phrasal verbs that are very common while talking, while writing, we are using during the case report, physical exam, reports of imaging tests and labs, and letter of referral. All of them we are practicing, so don't worry about it. And don't forget, your eye cannot see anything that your brain does not know. Let's remind this, and let's keep on reading and never forget to continue. That's the complete class. I hope you like it. Let me send you the poll. And while we are answering the diary poll for taking your attendance, please let me give you some information. Well, as you know, we didn't have classes the last week, Monday and Tuesday. And in a way, we didn't have classes. The schedule is moving for our final test. It was prepared at the beginning for being this Tuesday, but of course it's not possible because we have to take the 2 classes that we didn't have because of the holidays. And we are going to stay together until March 6th, I mean Monday and Tuesday from the next week, right? The final test is going to be on Tuesday, okay? In that order. On Tuesday, I hope all of you can get on time and we finish on time. It's going to be similar to the first, to the Model 1 final test with crosswords, a small crossword with matching columns. Now we are going to complete sentences. And moreover, we have specific writing questions, 2 questions for writing down. That's why I'm still expecting for some colleagues to send me your job. The exercises, case report, physical exam, well, everything we are writing them together, have an objective to prepare you for the final test and give you the key, could be the help to do this according, for not missing information at the beginning, for writing down correctly in English, and is very useful in order to understand all the information, and for approving the test, of course. We have now 80 questions by writing, matching, and everything, but each question for writing has a score of 10 points each. I mean, 10 points for the case report, and 10 points for the letter of referral. That is going to be 1 question of the test. If anybody didn't finish the exercise, well, this is the last week to do it. The ones that finish this tonight, I'm going to send the second exercise for writing down alone, so don't worry. And if there's any question, you can do it now or maybe tomorrow during the workshop, please. I didn't send homework last week. Well, many situations, personal situations that couldn't let me to finish preparing the file, but I hope I can send it now. But you are going to have the chance to prepare all the homework until Sunday. No, Friday. I'm sorry, until Friday. And it's going to take information from the 1, 2, 3 previous presentations. The last 3 presentations, from this week 2 and the Monday, the theoretical class, of course, are going to be in a small homework to send me on Monday. So it's going to be easy. The slides for the last class, for the Monday class, I'm going to send to you on Thursday, this Thursday, in order to check it and start studying. And we have to talk about it on Monday because that presentation has to be into the test. Okay. Any question about it? Is that clear, or maybe it's not clear? I'm not sure. Hi.
It's clear, Doc.
Okay, perfect.
It is clear, but if I have some question, I would like to have the opportunity to ask you personally.
Okay, if you want, Dennis, we can stay at the end, or maybe tomorrow during the workshop. Okay, thank you. Clear.
Thank you. Tomorrow it will be better for me.
Okay, if that would be better, don't forget just 15 minutes. We hope that would be enough. Okay, Denise, it's not a trouble if you want to stay now a little bit and then we can solve the doubts. Okay, and well, that's all I think. So the ones who fill the pool can leave the Zoom session. That's perfect for me, and see you tomorrow by working. So have a good night and see you tomorrow, dear people. Okay, I need 1 pool more. Luis, can you listen to me? Oh, yeah, I think he did. Well, in that way, I'm not sure if Anybody, if all of them sent the pool, that's why I'm gonna ask for the group. If anybody says that didn't answer, it's the moment to get back again and fill the pool. Ay, pero yeah. Well, that's okay for me. So let's finish this. So see you tomorrow in the workshop. Thanks for attendance and bye-bye. Let me stop everything.